Okay, so imaging of the stomach. We'll start with the anatomy and the parts of the stomach. The esophagus, as you know, comes down and opens into the stomach at the gastroesophageal junction. This is also called the cardia of the stomach. And from the cardia, if you draw a line horizontally, the portion above that line is called the fundus of the stomach. Below that line, there is the body. And then if you draw another line where the stomach changes its direction, below that level is the gastric antrum. The gastric antrum then opens into the duodenal bulb by through a opening called the pylorus, which is a small channel which is surrounded by the pyloric sphincter. The portion of the stomach or outline of the stomach that runs from the cardia down to the pylorus is called the lesser curvature, and the portion on the opposite side is called the greater curvature. Now, although the stomach looks like a two-dimensional structure on a barium image like this, if you look at the CT, it actually is a three-dimensional structure. So as you go down, there is the esophagus. As you go down, it goes through the esophageal hiatus and then opens into the stomach. That is again the cardia of the stomach. Now, if you were to draw a line from here horizontally, you'll realize that the fundus of the stomach is not only superior, it is also posterior. It is a posterior structure. Body lies more anteriorly, and the anterior-most structure of the stomach is the antrum of the stomach, which in the supine position is filled with air. Now, the antrum then turns backwards and then opens into the duodenal bulb somewhere around here. So it turns backwards and upwards as we saw on the barium image. The relationships of the stomach are well seen on CT. So the fundus is related to the spleen, but also importantly, it is related to the left adrenal gland. This is an important thing to remember, because when there is a diverticulum arising from the fundus, it can be mistaken for an adrenal mass of the left adrenal gland. As we go down further, the body of the stomach is related posteriorly. Body and the antrum are related posteriorly and inferiorly with the pancreas. Superiorly, the body is related to the liver. And as we come down, the pyloric channel is very close to the neck of the gallbladder. This again is a very important anatomic relationship, because one is that the diseases of the gallbladder can cause changes in the region of the distal antrum. And second thing is that when you are looking for the pyloric channel in patients with hypertrophic pyloric stenosis, identifying the gallbladder first goes a long way in helping you. The stomach is attached to the fissure for ligamentum venosum and the porta hepatis by the lesser omentum. And this is seen much better if you look at a patient with ascites, because the fluid kind of outlines the omentum. So this fat is the lesser omentum, and if you go up, it will extend into the liver, right there. Behind the lesser omentum and the body of the stomach is what is called as the lesser sac, and that communicates with the greater sac through the foramen of Winslow, which is right behind the duodenal bulb and the gastroduodenal ligament. Now, below the level of the stomach, there is this fat-containing structure, which is the gastrocolic ligament. The gastrocolic ligament then goes down into the transverse colon, and then from there downwards into the greater omentum. So these are the anatomic relationships of the stomach that we do need to know and to consider them while we are looking at the CT. So stomach can be examined by barium fluoroscopy or by CT or by MR also. The barium exam technique, it's always a biphasic exam. Whether you give air or not, there is always air within the stomach, so you will always have some kind of a double contrast effect, even if you are trying to do a single contrast exam. So that is something to keep in mind. But most of the times we do give gas granules. We give Easy Gas, which is an EZM product, and I don't know what you use, but this product, it's a powder. The patient puts it in their mouth and drinks a little bit of water, and it begins to fizz inside the stomach. The barium that is used is a high density but low viscosity barium. Why a high density? Because you want to be able to see the thin coating of this barium on the stomach wall, and low viscosity because you want it to be able to flow along the stomach as you move the patient back and forth so that it can actually coat the wall of the barium. If there is no barium coating on the wall of the stomach and you distend it with air, then there is really no double contrast study. All you have is an air contrast. By the way, gas granules are given first and then barium is given. After that, we put the patient prone and do a compression, which is with a wolf paddle. So this is put under the patient before we put them prone, and then we put them prone. And through this pump, you can put air into this balloon, and it inflates. And because the patient is lying over it, it compresses the stomach. So you can see here that even here you can see a mucosal relief view because of the compression by this balloon, which is this, and that is the frame of the wolf paddle. What does it do? One is that if there is mucosal relief, it gives you another view of the mucosa. And second thing is, it also helps you in the coating of the mucosa, because what you are doing now is pushing the barium into the mucosal crevices. And that gives you a very nice coating. And coating is all important. Now, the filming or the imaging is done in 3 positions because the barium and air are in different parts of the stomach in different positions. So one is in the LPO, where the barium is in the fundus and air is in the antrum. When I say LPO, which is left posterior oblique, it is in relation to the table, not in relation to the film, which is normally the case in radiography. Then after that, you start turning the patient to one side, and as they turn laterally, the barium will begin to flow along the lesser curvature into the antrum. When half of the barium has flowed, you put the patient back a little bit, so now they are in the RPO position, so that there is barium in the fundus and in the antrum, and you are seeing the body outlined by air. And then you turn the patient more so that they are lying on their front with their left side up, so that they are in the RAO position. The anterior right side is in contact with the air. And there is barium in the antrum and air in the fundus of the stomach. This is all because of the 3-dimensional anatomy. Here again, you can see the fundus is more posterior. Similarly, the bulb, the pylorus, it points backwards. So to fill up the bulb with air, you have to put the patient prone and then into the LPO position. So this is something that you learn as you do more and more bariums. And I think you should, because even though endoscopy has taken over a lot of the barium work, it is still a very useful exam. And if the radiologist won't do it, who else can do the barium? For CT, if you want to really do a CT examination for the stomach, you have to distend it with water. You can give gas granules if necessary. We usually give gas granules only if we are trying to solve a problem, if there is an area where we are thinking that there may be a mass and we want to outline it better, we may give some gas, but not otherwise. IV contrast is, of course, very helpful because it causes enhancement of the mucosa and of the cancerous masses. However, dedicated exam like this is done rarely. So most of the time, you will find a stomach that has some positive contrast in it. If the patient has eaten recently, as in an outpatient practice, you may have some food in it, and it will not be usually completely distended. So you have to take that into account when you're looking at the images of the stomach on a routine CT of the abdomen and pelvis, that there are some limitations to that. Now I'm bringing you back to the anatomy because I have just described to you about coating of the mucosa in different views. And so once you have done a barium exam, you will be able to see the mucosal features. There really are two mucosal features. One are the rugal folds, and the other are area gastricae. Rugal folds are much thicker in the body, in the fundus and the body of the stomach, and they are much thinner in the antrum. They may even be absent in the antrum of the stomach. Here you can see that is the opening of the gastroesophageal junction. This is called the cardiac rosette, meaning like a small flower. It looks like that because this is a puckered up fold where the esophagus is opening into the stomach. Thick rugal folds, and then as they come down, they become thinner and they are farther apart until they kind of disappear in the antrum. The area gastricae are a specific feature of the gastric mucosa where the barium has really coated it nicely and has entered into the crevices or the crypts of the gastric mucosa. It used to be said, and it is still true, that the test of a very good coating is if you can see area gastricae. But in our normal practice, you will find that area gastricae are seen from like about 12 to 40%. And it depends on what kind of barium is being used and how much you are making the patient rotate or compressing the stomach to get a good mucosal coating. But even in the best of hands, area gastricae are not always visible. But when they are visible, they are an important structure to recognize. And also, it's important to know that the area gastricae are smaller in the antrum than in the body of the stomach. And sometimes in the antrum, most of the area gastricae you will see are in the body. Antrum, you may not even see the area gastricae. If they are present, they are smaller than those in the body of the stomach. And we'll come to their usefulness in a little bit. So once you have looked at, once you have imaged the stomach, how are you going to identify the disease, or how are you going to interpret it? Again, you have to be systematic. We went through the systematic approach to GI interpretation, and I'm going to go by the same way again. So first thing is location. Second is orientation. Then you look at the contents of the stomach, caliber of the stomach, wall and fold pattern, filling defects and masses, contrast protrusions, and motility. So location of the stomach is in the left upper quadrant. However, stomach can be dislocated or be in a different location because of a number of conditions. The most likely cause of malposition of the stomach is a hernia, which can be a hiatus hernia, which is the commonest, diaphragmatic hernia, which can be traumatic or non-traumatic, but the stomach can be up in the thorax, or a ventral hernia where it is anteriorly and the stomach can come out through that in the epigastric hernia. This is kind of rare for the stomach to come out in this. It's mostly the bowel loops, but hiatus hernias are very common. Then apart from that, the stomach may be displaced by a mass or fluid collection or an enlarged organ in the body. So all those cause an abnormal location. Hiatus hernias are defined when the stomach has herniated from the abdomen into the chest through the esophageal hiatus. Esophageal hiatus is the hole in the diaphragm, is the opening in the diaphragm through which the esophagus enters from the thorax into the abdomen. And when the stomach comes up through that, only then it is called a hiatus hernia. If it comes out through any other opening in the diaphragm, then it is a diaphragmatic hernia. So I hope that is clear to you, the difference between hiatus hernia and diaphragmatic hernia. Now, if the gastroesophageal junction has gone up through the hiatus, then it is called sliding or type 1 type hernia. This is a very common hernia, and sometimes they can be very small and sometimes they are large like this. A lot of times these hernias will occur only when the patient is lying down in the supine position and the prone position. And when you make them stand up, they will go back into the stomach. You don't see that at all. In those kinds of hernias, you know that the esophagus has not become shortened. Whereas if a hernia is seen in the prone position also, and when you make the patient stand up, you can see the hernia still there, then there is a possibility that the esophagus may be shortened. And you must draw the attention of the surgeon to that, because if the esophagus is short and you're trying to reduce the hernia, that operation is going to be unsuccessful. Therefore, the surgeons have to operate on the esophagus and make it longer by doing certain procedures so that it does not pull the stomach back up after surgery. Now, a hernia can occur where the gastroesophageal junction is still in the normal position, but a portion of the stomach has herniated up adjacent to the esophagus. That is called a paraesophageal hernia. And sometimes the hernias can be large enough that the gastroesophageal junction, as well as the most of the stomach or a large part of the stomach, like in this case, the gastroesophageal junction is here, the fundus and body of the stomach, they are up in the chest. So this is an abnormal location of the that portion of the stomach. So the difference between sliding and paraesophageal hernia: in sliding hernia, the gastroesophageal junction is above the level of the diaphragm. In paraesophageal hernia, the gastroesophageal junction is below the level of the diaphragm. Very important, and it does not form a part of the hernia. Hiatus hernias can also be seen on chest x-ray many times. We see this very often because a lot of our population is older population, and it is very common amongst the older population to have a hiatus hernia. And when you see it on a chest x-ray, it will appear as an air-containing structure behind the heart, or it may, depending on its size, it may be located, mostly it is located to the left, but it may extend to the right depending on the size. Now, if there is no air within that hernia, then it can mimic a mass in the lung, right? So you have to be careful not to call one for the other, and to know when to do the CT or other imaging. Now, if there is an air fluid level in that hernia, it can mimic a lung abscess, because lung abscesses have air fluid levels. And therefore, it's important to, if you see an air fluid level, to think of, is there a hernia? And secondly, could it be a lung abscess? Is the patient really sick with fever and high white cell count? Because that is how the lung abscess will present. But this is a differential diagnosis of lung abscess is a hiatus hernia. Now, orientation of the stomach. You know the normal orientation, and I'll show it to you. But when you are assessing the orientation of the stomach, keep in mind that there are two axes of the stomach. One is the long axis, which is also called the axis of the organ. So when the stomach flips around it like that, it goes upside down, and it begins to look like this. So let us see the difference between these two. Here, this is the fundus. Of course, that's the fundus. This is the lesser curvature here. Here, the lesser curvature is lower. And this is the greater curvature, which is inferior here. Here, the greater curvature is higher. So the stomach is flipped on itself. And if you look at the direction of the duodenal bulb, here the duodenal bulb is pointing upwards. Here the duodenal bulb is pointing downwards, right? Because that's the pyloric sphincter. It is going down here. Here it is going up. So this is called the organoaxial configuration, or organoaxial orientation. If there is obstruction of the stomach, then in that case we call it an organoaxial volvulus. In the past, we used to call all of this as volvulus, but the problem is that when you start saying volvulus, the patients usually are obstructed, and that is what the surgeon thinks. So these are not uncommon. We see it quite commonly, and the obstruction in this one is rare. Therefore, call it volvulus only if there is an obstruction. Otherwise, it's organoaxial orientation. The second axis of the stomach, which is the short axis, is also called the axis of the mesentery. Why? Because the lesser omentum, which is the mesentery of the stomach, is attached here. The gastrohepatic ligament or lesser omentum is attached along the lesser curvature. Now, if the stomach flips around this, now that is a very serious flip. And what it leads to is this kind of a strange orientation. The fundus in this case is down. The body and the antrum are up. The pylorus is lying very close to the cardia here. This is the cardiac sphincter, that is the pyloric sphincter. See here how far they are. Here they are very close because this whole thing has flipped like that. And sometimes you can see the pylorus to be lying to the left of the cardia. Now this is a much more, and also there is a large hiatus hernia, by the way. This is a much more serious orientation, because it can cause, one is it can cause obstruction and volvulus, but second thing is because it is twisting the mesentery like that, because and the vascular supply is coming from through the mesentery also, then it can cause ischemia of the stomach and gastric necrosis. Therefore, important to recognize this. Now, when patients are symptomatic from this, they are vomiting like crazy because nothing is going through. And if you try to pass the NG tube, it will stop and it will not go any further. So that is the clinical triad for mesenteroaxial volvulus. So be very clear about these. The organoaxial volvulus, simple upside down stomach. Mesenteroaxial volvulus, where the stomach is twisted. Next, we look at the caliber of the stomach, like any tubular structure. Now, stomach volume is variable. If the stomach is empty, it is small. If you fill it up, it is large. We all know how large our stomachs can get. You know, we are all fond of eating. So when do we say that there is gastric dilatation? If the stomach looks big, then how do we know that it is actually dilated? And the way to look for that is to look for retained food when there shouldn't be any. So if a patient is fasting, as they are in when we are doing a barium meal, and a lot of times when we are doing CT, we ask them to fast for 4 to 8 hours. If the patient is fasting and there is retained food in the stomach, then that means that the stomach is dilated. Now, if the patient has recently eaten and there is food in the stomach, then you can't call it a dilated stomach because it is in normal physiologic state. Dilatation of the stomach can be non-obstructive, or it can be due to gastric outlet obstruction. Non-obstructive dilatation of the stomach can be seen in some physiologic conditions like diabetes, postoperative condition, and sometimes it can just be idiopathic. Oh, by the way, it is also seen in patients with vagotomy. People who have had their vagotomy for ulcer disease, the stomach may be dilated. Gastric outlet obstruction, on the other hand, the commonest cause is malignancy, scarring because of ulcer, scarring because of Crohn's disease or tuberculosis, and then, of course, the special case of hypertrophic pyloric stenosis, which occurs in infants. Because malignancy is the most common cause of gastric outlet obstruction, if the stomach is truly distended, as in this case, and you can see this food, this patient was fasting, you have to look for the transition zone where the obstruction stops. And therefore, you keep on following it. It will be in the region of the pylorus. And here you can see that there is an enhancing mass, which is a tumor, and that is a pyloric tumor. Now, the pyloric tumors that can cause obstruction, cancer is the most common. GIST can also cause obstruction. Lymphoma is less likely to cause obstruction because lymphoma is a soft tumor. In an infant, if the infant is vomiting a lot, and people can sometimes, the pediatric surgeons can feel a little mass in the epigastrium, then they start thinking in terms of hypertrophic pyloric stenosis, which is hypertrophy of the muscle of the pylorus. And if you do a barium study, you find that there's a string sign, which is a very narrowing pyloric canal, and elongated pyloric canal. That's a very specific sign. If it becomes more than 2 centimeters, it is diagnostic or highly suggestive of hypertrophic pyloric stenosis. The stomach may or may not be dilated much because these are kids. Their stomach is very active and it keeps on peristalsing even though there is obstruction. So this is a special type of gastric outlet obstruction. Nowadays, and I'm sure you have done a lot of this, we do ultrasound in which we look for the pylorus, the pyloric channel, and look at the muscle thickness. If it is more than 3 millimeters on each side of the mucosa, here it is 0.5, which is 5 millimeters, and 0.4, almost 5 millimeters here, that is diagnostic of gastric outlet obstruction. That's a diagnostic of hypertrophic pyloric stenosis. Also, the length of the pyloric canal, if it is greater than 15 to 17 millimeters, is another sign of hypertrophic pyloric stenosis. Now here I bring your attention back to what I was saying when we were talking about anatomy. It's important to recognize that the pylorus of the stomach lies very close to the gallbladder, and here it is the gallbladder. Every time, any image that you see, you'll find that the gallbladder is very close to the pylorus. And that is the way of looking for the pyloric, this hypertrophic pylorus in a child in whom you are suspecting hypertrophic pyloric stenosis. It is usually done with the stomach full, or the baby can be feeding, so they are pacified, and also it helps in differentiating the pylorus from the rest of the stomach. If you can't find the pylorus, then one of the ways to do that is look at the liver in transverse section and find the gallbladder. How do you find the gallbladder? You identify the middle hepatic vein and you start scanning downwards until you reach the gallbladder, because the gallbladder and the middle hepatic vein, they are in the same plane, top to bottom. That is how the liver is divided into the right and left lobes, by a plane passing through the middle hepatic vein and the gallbladder fossa. Once you have found the gallbladder, if you go a little lower, you should be able to find the pylorus. Now, gastric wall on barium studies is not seen, but you can see the mucosal features, the rugal folds and the area gastricae. Now, the abnormalities of the rugal folds can be localized or generalized. And localized abnormalities can occur because of epithelial diseases leading to fold destruction. We have talked about this before. If the folds appear destroyed, that means that the abnormality is arising from the epithelium, or subepithelial structures causing fold thickening and fold effacement, or stretching caused by extrinsic. Here there is no lesion. I am compressing it, so there is almost like an extrinsic impression of the bulb of this balloon on the stomach, but you can see that the folds are not thickened, they are not destroyed, but they are concave because they are being stretched over that balloon. Similarly, if there was a mass here, these folds would look stretched because of that. Now, rugal fold abnormalities, I told you, could be localized or generalized. Generalized fold abnormalities can be either fold thickening, which can be mild, but here you can see the folds are thickened. How do we know they are thickened? One is that they look thickened, but secondly, look at the folds in the antrum. There should not be that many folds in the antrum. I think there is some delay, but I'm going to continue on that. There should not be so many folds in the antrum. And in this case, the folds are markedly thickened, and these cases of fold thickening can be because of H. pylori gastritis. They can be because of lymphoma. Menetrier's disease, or eosinophilic gastritis. Now, the other generalized abnormality of the rugal folds can be fold atrophy, in which case the folds are completely gone. In this case, you can see in the fundus there are no folds at all, and there is complete atrophy of the folds. So generalized fold abnormalities can be fold thickening or fold atrophy. Now, fold atrophy occurs in atrophic gastritis, which also occurs in pernicious anemia. Okay. So next is the abnormalities of the area gastricae. And the main abnormality of area gastricae is when they become prominent. How do we know that these area gastricae, for example, here are prominent? Because the area gastricae in the region of the antrum are much larger than those in the region of the body in this case. Normally, body area gastricae are larger than the antrum, and you shouldn't see very many in there anyway. Another abnormality of the area gastricae is nodularity. And both of these are found in patients with H. pylori gastritis. It is important to recognize that because H. pylori gastritis is a very important disease from the point of view of all the problems that it can cause in a patient. On CT, the gastric wall can be visualized directly. So the things to look for in direct visualization of the gastric wall are thickness as well as the constituent, any abnormal constituent of the gastric wall. So assessment of the thickness can be made on CT, but you have to be careful that there are two conditions that are met. One is that the stomach should be distended, and the second is that you should assess the non-dependent wall of the thickening. So in this case, for example, you can see that the stomach is not distended, and this portion of the gastric wall appears thickened because it is in the dependent portion. As you come up, even in this non-distended stomach, because there's always some air, this portion is distended with air, and you can see there is no wall thickening. On the other hand, in this image, the stomach is nicely distended with water, and you can see that there is no abnormal wall thickening in the dependent or non-dependent portions. The other thing about gastric wall thickening is that if you have given IV contrast, like in this case, in the early arterial phase, you will be able to see enhancement of the mucosa, and that is called mural stratification. You can see the layers of the gastric wall. Now, if you can see the layers of the gastric wall, that means that this is a normal gastric wall, not thickened gastric wall. Okay. So on CT, you can have diffuse thickening of the gastric wall, like in this case. The stomach, even though it doesn't appear distended, you can see that the stomach is large enough. That means that that is all the amount of fluid it can hold. And there is, in the non-dependent portion also, the entire wall is thickened. And there is no stratification left. You do not see the enhancing mucosa, even though it's a contrast enhanced study. And that means that this is an abnormal gastric wall. And this patient had lymphoma, but Menetrier's disease, eosinophilic gastritis, Zollinger-Ellison syndrome, anything that can cause fold that can cause fold thickening can lead to this gastric wall um, thickening, diffuse gastric wall thickening. Now, gastric wall thickening can also be focal, and it can involve any part of the stomach, and this can occur in cases like lymphoma, which we see here, cancer, which we find here, or antral gastritis. Now, if you look at all these three images, they look very similar. So you cannot differentiate easily between lymphoma, cancer, and antral gastritis just on the basis of imaging alone. And therefore, endoscopy is imperative whenever you find local or focal gastric wall thickening. Then after thickening, we need to see just give a quick look at the stomach to find out if there is any air in the wall of the stomach, particularly if the patient is very ill. Air in the wall of the stomach is seen in emphysematous gastritis. Sometimes it can be benign, but here we can see that there is wall thickening as well as air in the wall of the stomach. Now, why are we saying that there is air in the wall of the stomach? Because it is present in the dependent portion of the stomach. So this air cannot be in the lumen, because otherwise it would come up into the non-dependent portion. But because it is in the dependent portion, we know that this is in the wall. Air in the wall of the stomach can occur in radiation, ischemia, or after treatment of lymphoma, because there is necrosis of the gastric wall in such patients. Coming to gastric masses, this slide I have taken from one of the previous lectures. Masses or filling defects in the stomach can be in the lumen, in the wall, or outside. So the masses in the wall can be epithelial or subepithelial, and then there are of course the luminal in the lumen and extrinsic on the outside. Luminal masses can be due to foreign bodies, food, or bezoar. These are the filling defects. Epithelial filling defects can be because of polyps, which are benign, or carcinoma, which is malignant. Subepithelial masses, you just have to see what are the structures in the submucosa, like lymphatics, smooth muscle, fat, nerves, fibrous tissue, blood vessels. So lymphoma, which is the most common submucosal or subepithelial tumor. Then arising from the smooth muscle, there is leiomyoma and GIST. From the fat, lipoma. From nerves, neurofibroma. And from blood vessels, hemangioma. And of course, GIST I have mentioned. Extrinsically, things that can affect the stomach are collections, particularly lesser sac collections, like a pseudocyst that occurs in the lesser sac in a patient with pancreatitis. Tumors and organomegaly outside the stomach can also cause mass-like extrinsic filling defects or extrinsic impressions. So in this patient, what we are seeing is that there is a large filling defect, and it has a very mottled appearance. It looks like food. It is within the stomach, and this patient actually came with obstructive symptoms and had not eaten. This is a very typical appearance of a bezoar. Bezoar is a collection of fibrous material or hair. If it is just fibrous material from plants, it's called a phytobezoar. If it is hair, some people eat their hair as a psychological problem. It's called trichotillomania, and they end up with trichobezoars. So not a good idea to eat your hair, or anybody else's for that matter. Epithelial gastric masses, which when they are benign, they are mostly polyps. Polyps in the stomach can be either inflammatory or they can be adenomatous. Inflammatory polyps are multiple. This is a typical appearance. It's been shown in many exams. It's a typical appearance of inflammatory polyps, and they are located in the body of the stomach, not in the antrum. Whereas adenomatous polyps, they are located in the antrum, and they are usually solitary. So if it's a single polyp, and they're larger too. So single large polyp in the antrum is adenomatous, and these polyps can develop into cancer. Inflammatory polyps do not. Cancers of the stomach are adenocarcinomas, and there are different morphologic types. So they can be polypoid, fungating, ulcerative, or infiltrative, which is also called the Linitis plastica. Polypoid and fungating are very similar. And in this case, you can see that there is again a polyp, but it is irregular. It is not like a regular polyp that we saw on the previous slide. And this part of the cancer, this is a different tumor. It's all irregular, and it has a fungating appearance. It is kind of breaking down on top. And so this is one type. Ulcerative we will talk about in ulcers. And this is Linitis plastica, where the tumor is not that much visible. You can see some thickening here, some thickening here. But what it has done is it has infiltrated into the stomach and caused narrowing of that part of the stomach, and that then results in what is called as a Linitis plastica, meaning this part of the stomach is like a leather bottle, and it cannot expand or distend, and it leads to gastric outlet obstruction. On CT also you can see the same types. Here there is a polypoid or fungating type ulcer as cancer. This is a part of the food, but look at the effect of this cancer on the wall. Here the wall is being pulled in. Do you see that? Anytime the wall is pulled in, that means that this cancer is infiltrating the wall of the stomach and is therefore not a filling defect from food. It is a filling defect from cancer. Ulcers I'll show you in the further on. And here what we are finding is that the cancer has infiltrated the wall to a large degree in the antrum, and this is again typical of Linitis plastica. So just a word about Linitis plastica. Basically it is stricturing of the stomach in the distal portion with wall thickening and a stiffness of the wall. Most common cause is infiltrating cancer. Very rarely lymphoma can cause it. Usually if a lymphoma causes this, it's a Hodgkin's lymphoma, not non-Hodgkin's, whereas non-Hodgkin's lymphoma is much more common in the stomach. So lymphoma is a very rare cause. Crohn's disease can cause it because of fibrosis, and TB can cause it because of fibrosis. So Linitis plastica. It is a question that people love to ask in the exam. Going to subepithelial tumors, lymphoma is the most common subepithelial tumor. Non-Hodgkin's lymphoma is the commonest lymphoma. It's almost always non-Hodgkin's. Very rarely Hodgkin's occurs, but almost always it is non-Hodgkin's. And in that, it is the large B-cell type lymphoma that involves the stomach. Now, stomach lymphomas can occur because of secondary involvement of the stomach. If there is lymphoma elsewhere, then stomach may get involved. Or it can be a primary lymphoma arising from the stomach itself. Stomach is the most common site of a primary extranodal lymphoma, and it arises from this tissue in the wall of the stomach, which is called MALT, which is basically mucosa-associated lymphoid tissue. And initially it starts as a low-grade lymphoma, but then it degenerates into a high-grade B-cell lymphoma. And lymphoma in the primary lymphoma in the stomach has an association with H. pylori infection. We know that H. pylori can cause gastritis. We know that it can cause duodenal ulcers, but it can also cause lymphoma. So H. pylori infection is something that the gastroenterologists are always looking for, and they treat it actively. Morphologically, lymphoma can appear as fold thickening and nodules. It can appear as a mass, which can be entirely within the stomach, or it can have an endoexogastric appearance, where there's a mass inside and outside the stomach. So you can see multiple nodules from lymphoma, which can be small, or they can be large, and there can be marked fold thickening. Again, lymphoma, although there's a differential diagnosis for fold thickening, as I had told you before. On CT, they can appear as masses and wall thickening and endoexogastric type of masses. In this case, you can see this is the mucosa. It is coming up. It's a submucosal mass, and it has caused ulceration in this. And lymphomas are very likely to ulcerate, especially when they are like this endoexogastric type lymphomas. Also notice that when it invades outside the wall of the stomach, the margin of the lymphoma remains very nicely sharp, whereas the margin of a cancer will become ill-defined as it invades outside. So lymphomas have a tendency to ulcerate. Now, when there is a mass in the stomach, the question arises, is it lymphoma or is it cancer? 95% of masses in the stomach are cancer, 5% are lymphoma, which is quite a high prevalence. So if there is fold thickening, things that will favor lymphoma, if there is marked fold thickening, then you consider lymphoma rather than a cancer. If there are multiple lesions, then you consider lymphoma rather than cancer. If the exogastric margin, as I showed you, is well defined, consider lymphoma. And if there is extensive lymphadenopathy, consider lymphoma. Now remember, gastric cancers can also extend to the lymph nodes, but those lymph nodes are usually around the stomach and they're not very large. But what they say is that if there is lymphadenopathy going down below the level of the renal vessels, then that means that it is extensive enough that you are dealing with a lymphoma rather than a stomach cancer going into the lymph nodes. The other second common subepithelial tumor is a GIST, or gastrointestinal stromal tumor. Stomach is the most common site of gastrointestinal stromal tumors. They can be benign or malignant. On the basis of imaging alone, it is not possible to say whether a GIST is benign or malignant. Signs of malignancy are if it's a large GIST, if it is heterogeneous enhancement, and if there are metastases. Now, GISTs are usually submucosal masses like this. You can see the nice mucosa on top of this tumor, which is arising from the stomach, and it has a nice big exogastric component. Another GIST, that's the stomach, the fundus, the body, the antrum. Here is a large tumor, submucosal, you can see here, with a large exogastric component. They are also very prone to ulceration like lymphomas. So when you see a mass with ulceration, it is not easy to say whether it is lymphoma or a GIST or cancer, except that when the ulcers are large, they are more likely to be lymphoma or GIST. In this case, you can see there is something that is invading the wall of the stomach. It's a submucosal tumor. It's otherwise very smooth. This is not a cancer. It is a submucosal neoplasm. And there is a large ulcer on top, GIST or lymphoma, either or. Other subepithelial neoplasms, one of them is seen here. Do you see it? Well, there is this air in the stomach, and then there seems to be an air bubble in here. Now, whenever you are wondering if if a dark thing like that is air or fat, all you need to do is put it on lung windows. The air looks dark, fat becomes gray like the rest of the fat. So this is a very easy method to differentiate, and that is why we asked you to look at all the abdominal images on lung windows to make sure that you're not missing the presence of air. But it also helps you differentiate between fat and air. So this is a lipoma. Lipomas can be asymptomatic, or it can prolapse, particularly if they are in the antrum. They can prolapse into the duodenum and cause obstructive symptoms. Another subepithelial tumor with a little ulcer on top. This is a very small one. Usually small gysts and lymphomas do not ulcerate. But if you have this kind of an umbilicated lesion, meaning an ulcer with a little navel or umbilicus, a nodule with an umbilicus to it, then the things to consider are neurofibroma, pancreatic rest, if they are single. If they are multiple, still these two, but then you have to consider metastases, particularly from melanoma. Another subepithelial tumor here. And this one, when we put the ROI on it, this was fluid signal intensity. So this is a small duplication cyst of the stomach in the wall, and it can appear as a subepithelial tumor. Extrinsic gastric masses will give rise to stretching of the folds, or if they invade the wall of the stomach, they may cause irregularity. In this case, this mass has an impression with obtuse margins, sulcus angle, and the mucosa is kind of irregular because it is invading into the stomach. This was a pancreatic cancer which had invaded into the gastric greater curvature of the stomach. Now, coming to contrast protrusions, these are usually depressed lesions. They can be because of diverticula, erosions, ulcers, perforation, and fistulae. So stomach diverticula, the only thing you need to know about stomach diverticula are that they are not uncommon. They are almost always present in the fundus. I have not seen a diverticulum elsewhere in the stomach. Yeah, you can see them in the duodenum, but not gastric diverticula. You see it only in the fundus. It looks like a typical diverticulum. This is not the place for a peptic ulcer, so I wouldn't worry that this could be an ulcer. Ulcers occur in the body and antrum of the stomach. The fundus is protected. And here the other anatomical thing comes up. They can be mistaken for a left adrenal mass. For example, this. It would be difficult to say whether this is a diverticulum, or if you were not careful in thinking, you could think this is a left adrenal mass, but this is actually a diverticulum arising from the stomach. Now, of course, if it contains air, then you know that this is a diverticulum. It's not a adrenal abscess, because adrenal abscesses are extremely rare and there is no inflammation in the fat around it. All we are seeing is an air fluid level. So it's in the gastric fundus diverticulum. Erosions of the stomach, you have to be able to diagnose these. They are shallow ulcers, less than 2 millimeters in depth. They do not invade, they do not go into the muscularis of the stomach, they are in the only in the epithelium. They are most likely to occur in the gastric antrum, especially when there is antral gastritis, and they are better seen on face as barium collections. So you can see them here. All these are gastric erosions. Now, if they have this halo, dark halo around them, they are called complete erosions. If there is no dark halo, then they are incomplete erosions. The reason you should know about incomplete erosions is because it can be difficult to recognize them. Most of them, though, have a halo on them. When there are erosions like this present, the most common cause is going to be nonsteroidal anti-inflammatory agents. Alcohol is another one, alcoholic gastritis, viral infections, Crohn's disease, hemorrhagic gastropathy, and iatrogenic trauma, nasogastric tube, or recent endoscopy. The interesting thing about them is that they are not typical in H. pylori gastritis. If you see these, this is not the picture of H. pylori gastritis. What is the picture of H. pylori gastritis? Thickening of the area gastrici and presence of nodules. Okay, now the next is peptic ulcer. So you can see it in profile when it is called an ulcer niche. There's a large peptic ulcer here. Or you can see it en face when it is called an ulcer crater. Now, even on double contrast views, you can see it sometimes as a niche, and it may or may not be filled with barium. This is ulcer niche is usually seen on single contrast studies. Ulcer craters are always seen on double contrast studies. You cannot see them on single contrast studies unless you really do a lot of compression of the stomach. These are deep ulcers. They pass through muscularis. They are characterized by what is called as penetration. Because it is not on top of a mass, the ulcer outline extends outside the outline of the stomach. So if you were to join these, this lies outside the outline of that. That is called penetration. And penetration is a sign of benign peptic ulcer. They always have smooth margins. If the margins are not smooth, don't call it benign. And in profile, you can see an ulcer mound sometimes, which is edema around the ulcer. Don't mistake it for a mass. And this thin line here is called Hampton's line. This is a filling defect produced by the mucosa overhanging the ulcer, because as the ulcer forms, it goes underneath the mucosa. So it can form this filling defect that is called Hampton's line. If it is thin and not nodular, then it is a benign ulcer. En face, you will see radiating folds going right up to the margin of the ulcer. And the folds are smooth, and there is no nodularity of the folds. They are thin folds. As opposed to that, let's go to the malignant ulcer. So malignant ulcer occurs on top of a mass. Therefore, it does not penetrate. If you join the outline here or here, this ulcer is not going out through that. It is sitting on top of a mass. So lack of penetration is a sign of malignancy. The margins of the ulcer are irregular. If there is an ulcer collar that is formed, which is similar to which in benign ulcers occurs because of edema, here it is because of the tumor, then it is irregular. The folds surrounding the ulcer are thickened, and they may not extend all the way up to the margin of the ulcer. And here is a very typical sign. We don't see it that often. It is called Carmen's meniscus sign, which is basically, if you compress this tumor, what you will find is that the margins of this ulcer, they join together and produce a filling defect, and this is the barium in this part of the ulcer. So that is called Carmen's meniscus. So Hampton's line is a sign of benign ulcer. Carmen's meniscus is a sign of malignant ulcer. Fistulae can occur as contrast protrusions, and you recognize them if the barium has entered another structure instead of going the normal route. So here what we are seeing is that in very early part, you are finding that the barium has gone into the colon. So this is a gastrocolic fistula, usually produced by malignancy, but can also be produced by aspirin, by the presence of an perforating gastric ulcer, and also Crohn's disease. Then gastropancreatic fistulas, here you can see that's the stomach. Here is a fluid collection, and there is some air within it which has come from the stomach. Contrast can also enter. Here you're not seeing it. And this patient had a pancreatic pseudocyst, and a cyst gastrostomy was performed by the surgeon, but it is producing a gastropancreatic fistula. It can also occur in acute pancreatitis. Now this is a cholecystogastric fistula where contrast has entered into the gallbladder because of the communication between them. Usually it is caused by the passage of a stone from the gallbladder through the wall into the stomach, so it penetrates through that and causes a fistula. So in summary, I want you to remember the 3D anatomy, the effect of position of the patient position on the appearance of the stomach, the points that we use for systematic examination. I want you to assess the stomach contents. Anytime you look at the stomach, don't just look at the wall. Look at the contents and see, is this food really what the patient has just eaten, or is it food residue from last night? The commonest tumors of the stomach are cancer, lymphoma, and GIST. I want you to be able to recognize erosive gastritis and differentiate between benign and malignant ulcers. That brings us to the end